Hello, I'm Dr. Bill Wyatt. I'm a general dentist who's been practicing orthodontics only since 1970. I did some temporomandibular joint work that's kind of combined with the orthodontics also. I'm a member of the American Orthodontic Society, and this is a society dedicated to the education of general and pediatric dentists in orthodontics, and we're interested in these general and pediatric dentists doing excellent orthodontics. We have a good organization, and if you're interested in orthodontics or want to learn it, there's some excellent instructors in the American Orthodontic Society, and we have a good organization, journal, take boards in it. So I'm going to talk about a subject that I've been interested in for years, and I never did find out exactly what caused it to happen, but I noticed that many adults had these kind of sucked in bicuspids, and both upper and lower just kind of cup in. The cuspids look like they could stand the force, but the bicuspids would kind of tuck in toward the tongue, and I could not figure any way that you could tighten your muscles up and make them squeeze in like that. But one night I was fast asleep, and I woke up a little bit, but not completely, enough to see that I had a tremendous vacuum sucked in my mouth, and my masseter muscles were fairly relaxed, but the vacuum is created by my tongue. I swallowed a few times with a good seal, and the pressure was on my cheeks and pushing against my bicuspids, and I figure this almost has to be the thing that caused it. So I'm going to go through about 4 cases. I think I'll do it in 2 different phases here, but anyway, the first case is a lady that worked in the office. Now I'm going to draw on these pictures and erase it and everything, but you can see how the arch form would preferably be out something like that. This side is not in very much, but I think the left side of the mouth is quite a bit tucked in like that. And then we'll go show the lower, and the same thing is down here where the cuspids stayed out and the bicuspids went in. We've got some crowding down here, maybe a little depth of bite there that we would want to get rid of. All of these 4 cases that I'll show you have other problems too. You don't run on a orthodontic case with just a single problem very often. So here's this lady who worked for me, very fine lady, was a good assistant and everything, and looking at her face you don't see much evidence of this at all, but she had some TMJ problem, and we needed to bring the maxilla forward a little bit so that the jaw could move forward. Just a couple of millimeters or even less than that would solve the TMJ problem for her. Now, a little extra depth of bite there, but you see how these teeth are tucked in right in here on this side, and they're tucked over on the other side also. Now when we get through with this, this will be rounded out, both upper and lower, and we tip these upper teeth forward, give them a little more torque, and that'll bring the maxilla forward. We could tip the bicuspids and cuspids and molars, and that also would bring the maxillary teeth forward, and the jaw could follow them and still interdigitate, but yet have a more forward position for the lower jaw there for those teeth. So let's look at how this turned out. I'll try to cover a lot of it as we can here fast. Now you can expand teeth, and a lot of people don't think you can. They think they're going to run them out of the bone. But we expand hundreds of cases of teeth, and just show you years after they're out, they're holding up, they're stable. You see this bony ridge here. As we go out with it, teeth aren't going to move out of that bony ridge. If you bring the whole group out, you see the bony ridge will go out right with the teeth. And that's hard for people to understand, that teeth carry their bone with them. If you move groups of teeth together, they just carry the bone with them. I mean, if a kid goes in here and sucks his thumb, he doesn't pull his central out of the bone. The bone and everything moves out here as he's sucking the thumb and pushing out there on that, putting pressure on that. So that's just happens, all the time. So we can look at both upper and lower jaws, and they're both expanded. I mean, constricted like that. We've got a lot of crowding here, and we'll solve that too without taking any teeth out on this lady. Now, we tried to advance her maxilla to solve her TMJ problem with a type of headgear. This fits around the head pretty tight and comes down. It has some little plates here that fit against the maxillary sinuses up here. And then you try to slide the teeth on the maxilla where you're holding it back here. Now, this is a pretty good idea, but it just doesn't work. The pressure on the tissue right here under the eye just gets sore as heck, and they just won't wear the things. So you can't use a headgear very much. If you take a Hickam type chin cup with a little forks up here that comes around and comes over the head, you can pull forward on the maxilla, but you got to push backward on the mandible to do that, and that, of course, backing up the mandible back here will back up the condyle, and you don't want to do that in a TMJ problem. So you have a problem if you say wear some class 3 elastics. They pull back on the mandible too as they pull forward on this. Now, I found that people can wear class 3 elastics during the daytime when their muscles are holding forward, but at night when their jaw relaxes, this class 3 pressure will come in here on the joint, and they'll have a discomfort if they're, leaning that way to start with. Anyway, this headgear doesn't work good. I'll just save you the problem of trying that. I couldn't get anything with it. All right, we opened the bite and we expanded the case, and we did some tipping of the teeth, which will tend to bring the maxilla forward, and you can reverse tip the lower and take a little torque out of them, and that brings the teeth back, but the jaw can be out far enough to solve a TMJ problem. These are just little things on working on TMJ that you might want to, some people will be interested in that. All right, so during this time we straighten the teeth up, and we'll be expanding both buccal segments, upper and lower. All right, this is already expanded to some extent. We'll go ahead and expand a little more. This is on the lower, so expanded, and we're getting space enough for these teeth. We'll continue working on that. Excuse me. Okay, we got a little midline problem, so we're using some midline. Well, I take that back. We're using a little reverse headgear. That's the elastics from the reverse headgear. Here we're pulling the lower molars buccally by pulling the upper molar lingually. That's, you can jump across by it, stuff like that with that material. And so here we go along. I'm not going to show a lot of the mechanics of doing this. We're using some real narrow brackets that have little wings on them. That gives you a greater inner bracket space, allows you to torque better, and engage better in these little wings. You can bend them up or down to rotate the teeth however you want to with that. These are excellent little bands, and I mean brackets, and if you haven't used them, I started using them one time and we didn't have good sealants and they'd get junk underneath these wings and they were getting some decalcification, so I just went to straight single brackets. But I think these are much better for you to start. Use a single bracket with wings if you're used to it. Now they're selling all kind of fancy brackets these days. You can do anything you want to with these brackets. Now we dropped the lower anterior teeth, dropped the brackets down here, and then we kind of came up, you see, right along here to go into the molar. You can put these down wherever you want to as long as you keep the incisal edges of the teeth lined up. So you can hide the lower anterior brackets on adults like to do that. They've got long clinical crowns. Alright, we've expanded this quite a bit right now, and it's looking good. She's got a little tori, that didn't make any difference. You'll notice that the lower anterior teeth are pretty well lined up now, so we've gotten a good bit of expansion there. You look at the facial structure, it's not much different. It'll be slightly fuller, but not a great deal. Now she's got a beautiful smile, and you see teeth all the way back down here, whereas before it looked like a little shadow back in that area. Now look at them as we finish. It's not perfect. There may be a little two-side discrepancy, something the midline's not exactly on, but we're in a good class 1 relationship, and we've advanced the mandible, and the TMJ problem is over. Now this has been since 94 when we finished it here, and now it's 2015, and so this has been out of treatment now for quite a number of years, and she's still doing quite good. No TMJ problem, everything else. I haven't seen her in the chair in a long time, but this is finished out good class 1. We've advanced the mandible, gave it plenty of room. We lined these up, and I bonded these together, and she wears a good retainer with a bite plate, and we have no TMJ problem. And you can look at where we started and where we finished. We finished it in 94, and now it's like 2015, so that's about 21 years ago we did. So you look how much we expanded the upper arch compared to the lower arch, and we've got a much better smile line. Person has a lot more space in here. They have a better airway too when you get through that, and their jaw is further forward, and she has no TMJ problem at this time. And this has been years ago. I know the lady. She worked for me, and she lives, outside of Fort Worth here, a little ways. Okay, here's another case now. A real nice young lady who's got this same problem. She's even in a crossbite right here. On the other side, it's not the crossbite, but it's cupped in quite a bit. Now, good class 1 relationship. I mean, that's fine. I don't think she had any TMJ problem. It's just this crossbite. And we went ahead. Now we're going to expand the heck out of this. And we do that on hundreds of patients and have never had any problem with it. And all this baloney about pushing the teeth out of the bone if you expand them is ridiculous. If they did, a kid that have his centrals out in his hand, when he sucks his thumb, and you can see the bony ridge after we've expanded the case. This is 1987, I think, when we started this. I've got some panorexes, a bunch of panorexes on this case. I'll show you. This was the first one we did. A good pretty good class. Well, it's an excellent class 1 over here. And I have the patients bite together, and that gives me the molar relationship and the interdigitation. This side is slightly class 2. You see, this needs to be further forward. This point needs to be going up in that groove, and this one over here. And we need to open the bite, you see. All of this is registered on this Panorex. I couldn't show it on the picture, but you also see the condyle up in here on the Panorex actually. So it's a good thing to do. With the old type Panorex, we could, in fact the new ones we're using that too, we have them just bite together and where they chew, and we take the Panorex at that point. I had to split these, you see, to do that. Or we use an intruding arch here to bring these teeth down to open the bite. And this is the second Panorex, I think, that we've got. And here is the third one. Looks like we've finished the case. And now we've got pretty much class 1. This is a good class 1 there and a good class 1 on this side. And the bite has been opened. You see the amount of overbite and overjet. You can see the overbite through this very good. Now, looking at it cephalometrically, you can see what we do here. We're going to open the bite. We're going to advance the class 2 side, but leave the class 1 side pretty much like it is. You can see it sitting there. We've opened it up. Now we look at their condyles, and you can see this is biting together. The head of the condyles back in here, and here's a kind of relaxed situation, and here's the jaw advanced. Now if you're not used to looking at these, you see the thing that, let me erase this, what advanced out here, you see the two different deals. You see the two things in here, and you can tell what is the condyle as it moves out. So this is the condylar position is good. Had no TMJ problem at all. I don't recommend X-ray in every case, but if they have any TMJ problem, we would take transcranials. Now we've got these CT scanners, which I've virtually quit practicing, so I don't get to use those, and they're really nice. Now here we've expanded and intruded the arch. This arch wire here would be way down here. We pull it up, and that brings these teeth down like the intruding arch right here. Here we use a little different brackets. These are just singles without wings. And we've got this intruding wire. You can see it's got a little spring, and it's down here. We raise it up, hooked it on these front teeth, and it's bringing them down, and we level. And by the way, this is the fastest way to level an arch that I know of. You can put this intruding wire on a case with wildcat wire or a little flexible knife tie wire in there and open the bite from the day one, you see, and you'll have it open before somebody else gets it, before they can put a stiff enough arch wire to start opening. So I strongly recommend these intruding arches, and I started using those about 35 years ago, and called them intruding arches back then. So other people have come along and started using them later, but they're an excellent way to do. Now here, if we're advancing the mandible or something and we want the teeth to slide, sometimes we'll put a little acrylic on there. If you're class 2, it slips back much easier if you eliminate the interdigitation friction of class 2 treatment. So that's just a little strip of triad acrylic. Open the bite, and that slides that back easy. And we'll run through this pretty quick. Now when you're expanding the upper arch and you don't have the second molar bandage, you have to put a little tongue or a little bar back there and carry that tooth out with it while you're doing it. If you do much expansion now, you've got to learn how to put buccal root torque so that you torque the roots of this teeth out as you expand it. You see, if you just expanded, the crown will lean over, and you want the roots to go out with you, so you put buccal root torque in there. We'll cover that in a lot of different of these lectures. I'm trying to get all this stuff recorded down before I pass out of this world. I'll never get it written down, so I'm trying to record it and give it to as many people as I can. So we got it lined up real good. We're using a rectangular arch right now, so you can come out with a double. You can put a little reverse curve in the rectangular. Alright, here's the young lady, and she's got a nice smile. And here were the teeth to start with. This was 87, and that's right side. And here is the left side where she had the crossbite. That was in 87, and this is 91. This is a year or so after we'd finished the case, but this is the way it looked then. Now, that's interdigitated real good. The crossbites jumped. We've expanded these. These teeth did not move out of the bone. There's bone structure on those bicuspids, and you can look at them 25 years later, and it'll still be there. So people that don't think that's true, they just have to believe it. I don't know. I told one old boy, I came up and just swore him down. I was running him out. I said, well, I'm not going to skin them just so you can see it. Now we've got the CT scanner so you can show them it is. So we've expanded these teeth right here, and you see them here. They're straighter up and down. We've expanded. We've opened the bite. It was down there, and now it's up here. So we intruded this with the intruding wire. Maybe we brought this up a little bit, but not much. We expanded the whole blooming thing. I want to see the lateral here, so compare the lateral over there. Now I mark all over this. I hope it helps you follow what I'm talking about in here. So now we've finished her, and we put her in a retainer. We put everybody in a wraparound retainer. We don't go across the occlusion with anything. I just don't go with that. You can come out the back, come up and put your expansion loop in here on both sides. You can expand this or contract it. We build this, and then after they're going, we have them set normally and put a little soft acrylic up here and have them bite into it. So we, on any deep bite case, we put a little bite plate, and if they wear that retainer, that thing will never deepen. But some people leave it out and it deepens some, then they put it back in, and their back teeth don't touch. They hit out in the front, and that sometimes causes problems. So you need to understand that. But if they will stay with this thing, they just will never deepen if you wear it enough. Here on the bottom we had a little crowding, but not, this cuspid right here is pretty crowded, and this is a little crowded, but this is lined up now, and this looks darn nice, really, to fit in there. And I don't know, it may be a little of photography tilted it. I didn't intend to, but it looks like I got the picture, little mirror shot better. Anyway, it looked a darn lot better in 91 than it did in 87. So here it is, and here's the upper retainer in place, and the depth of bite, and it won't deepen anymore as long as they stay with that retainer. It'll hold it right up there. But people wear it 15 years, and then they stop all of a sudden. These teeth touch something all the time, and you stop it, then these teeth don't touch anything, so they tend to over erupt to some extent. But if people stay with it a long time, the bite will never deepen as long as they're using that enough. Okay, looks good. I'm proud of that one. And this is a retainer. You've got those lower teeth come up, touch this right here, and they stay there pretty good. Now, here is the lower teeth looking at them without anything on them. And that's the end of that case. Now, I think I'm going to stop this one and make a second phase thing. So I'll go here and just stop this